Okay, so our topic today is comorbidities associated with obesity. This is a pretty short chapter in Edinger, and I sort of gave it a whole tutorial because it really didn't tie in with the next topic. So I couldn't kind of do them in the one. But if you've got any cases or anything that you wanted to talk about, very happy to make this more of a sort of discussion. I don't have a lot of material to cover at all. Also flew in from the US yesterday, so I might fall asleep midway through. But I think we'll probably either get through what we get through and then have an early mark or see how we go. All right, what is obesity? I'm starting easy, guys. Come on.
Well, just being too fat.
Yeah, exactly. Yeah. So it's kind of going from a little bit overweight to morbidly overweight or markedly overweight. So
Is it 30%? Is there like the 30% cutoff between overweight and obesity relevant for dogs?
I don't actually know because we don't really have like a BMI sort of index in dogs. So I didn't see a proper definition of it apart from like body condition score 8 to 9 out of 9. Probably 9 out of 9 realistically. And I think that lack of a definition is a problem when you review the literature. A lot of the papers that are sort of referenced in this chapter are referring to overweight dogs, not obese dogs, and the metabolic implications of that are quite different. So they've sort of drawn conclusions saying there's not an increased incidence of cancer or respiratory disease or anything in overweight dogs. But when you look at the studies, only 2 out of the 17 were actually obese, and the other ones were only overweight, and maybe the conclusions would have been different if they were dealing only with obese dogs. So I think that's an interesting point to make, is that we don't have a proper definition, and maybe we should just sort of say those 9 out of 9 dogs. I know it's subjective, but that's where we start to get the metabolic changes associated with obesity.
Yeah. Well, one of the things I've started to do is when people don't believe their dogs are overweight, I say, well, just look up the breed standard.
Yeah.
I did for one lady, and I got as big a fright or nearly as big a fright as she did, because I think the dog was 20 kilos and the breed standard was up to about 10. And I thought, well, a dog should be 12 or 12 or 13 or so.
But it's 10, yeah. I'm quite amazed at how under discussed obesity is often. But I think I probably see a very biased sort of case load, but particularly the dogs with the dynamic airway disease, collapsing tracheas and stuff like that, and the impact that obesity, you just look at their x-rays and you're like, there's so much pressure on that thoracic inlet, there's so much fat inside the thorax, and that chest wall is 3 times heavier than it should be, or 3 times thicker than it should be. So of course there's going to be some impact on respiratory function. But a lot of these dogs, the owners are like, are they overweight by the time they get to me, and they've seen 3 different vets in the interim. And my sister's got this Labrador who's beautiful, lean, can't see his ribs, can feel them if you dig. And she was told by the vet that he was underweight. Like, no.
Oh, what I've noticed is it's a matter of perception, because when you look at people on the beach now,
yeah,
and look at a film of people on the beach back in the 50s, there's an enormous difference. So what we perceive now as being normal was actually overweight.
Yeah, completely.
Yeah. I've just noticed that in Europe, actually, like not even in the 1950s, in like 2 months ago, noticing actually like the French and Spanish body condition, like how like skinny that they all are. Not everyone, obviously, but just like it's pretty compelling that like there's definitely something different with their microbiomes and their dietary habits in Europe and exercise habits.
Yeah, and I was actually going to say, Jeff, I think that it depends what beach you're on and what the culture is and what's normalized in those little microclimates sort of thing. Because there's certain areas where, you know, everyone you see is quite lean, and often socioeconomic associations there. And there's areas where everyone you see is quite big, and it's just sort of what's normalized in those little communities, that what you're seeing every day is like, oh, it's okay to have another donut, or not. So what we said obesity is being overweight. What tissue is increased in volume in obesity?
Adipose.
Yeah, good. Excellent. So what is the adipose tissue's function?
Survival.
So storage. Storage.
Well, it's now regarded as a hormonal.
Yeah.
Is it leptin that it?
Yeah. This discussion. What does leptin do?
Satiety.
Yes.
Satiety.
Good. Yeah. How do you say that?
Inflammation. Pro-inflammatory.
Leptin is pro-inflammatory. Is it the leptin or is it the adipose tissue itself?
It seems like it's leptin because I just went to a conference with a boarded nutritionist and they were saying like leptin induced, like leptin has a pro-inflammatory drive pathway of its own.
Oh, interesting. So let's go back to function. So satiety is the main function. So why, if we say that the amount of adipose tissue you have is directly related to the amount of leptin you have, and it's sort of linear, is that better for you? Like it's just increases? Okay. So if you've got more fat, you've got more leptin, right? So why are obese people eating more? Shouldn't they not be hungry?
Leptin resistance. Yes,
good, exactly. So the effect of leptin is lower the fatter you get. So you've still got more leptin, but there's less receptors and less receptor responsiveness. Where are leptin receptors? I don't know the answer to this. Sorry.
It's a good question.
Is it in the microglial cells in the brain?
Oh, that's very specific. It's in the brain somewhere. But I think it might be hypothalamic. And then triggers that pathway to, I don't need to eat anymore. The reason I say I don't know the answer to this is because we know that leptin has multiple functions because they've discovered leptin receptors on cells in lots of different areas in the body, but they don't know what functions it has. And as Matt has just suggested, that maybe having a role in a pro-inflammatory role. So we're going to be discovering more and more about leptin as we start looking at obesity as a disease in itself, progressing to other diseases. So leptin causes some inflammation. What else in adipose tissue? Why is obesity associated with an inflammatory cytokine profile?
Is there other mediators like adipokinin and lipoxin and other pro-inflammatory cytokines?
Yeah. So there's lots of different cytokines produced. The main thing is that as adipose tissue grows, it almost outgrows its blood supply. So there's a sort of degree of relative hypoxia in the cells that are quite far away. And we know that hypoxia is associated with what kind of damage?
Oxidative stress.
Yeah, exactly. Yeah, which is then going to it just means that the more adipose tissue or adipose cells you have, the more of that kind of hypoxia and cytokine profile you end up with. And that's a simple way of thinking about it.
Interesting.
Yeah.
Because it kind of behaves like a tumor then. Like it's like
exactly.
It's like a tumor microenvironment.
Yeah, exactly. And interesting, once we start talking about the adipose tissue impact on cancer development, that there's multiple different ways that fat can promote cancer growth and much more interesting in humans because we don't have proper associations in dogs, but let's get there when we get there. So as clinicians, you're presented with a 40-kilo Labrador. What limitations does that dog's obesity pose to your ability to diagnose them with the disease?
Finding a blood vessel.
Yeah, totally. Yeah, absolutely.
Palpating abdomen, all you feel is fat.
Yeah, exactly. Can't get any detail. Anything else?
Dulls auscultation a bit as well.
Absolutely. I've definitely missed murmurs in fat dogs for sure. What about if we need to do x-rays or ultrasound?
Can't get them on one plate.
Capacity.
You have to move them around.
Yeah. Yeah, exactly. So size is just difficult. What about contrast with fat dogs?
Opacities differ.
Yeah. So if you're looking at particularly lungs, I find is the hardest. They've often got lipomas as well. So there's kind of lumps and irregularities in there, in the density that's sort of overlying their chest. Looking at the abdomen, I think sometimes it's an advantage because it gives you quite good soft tissue detail because you've got the fat contrast in there, as long as your radiology machine is capable of the depth that you need. What about ultrasound? I'm biased, but my shoulder hurts thinking about it.
Well, there's a standoff pad.
Yeah. So the deeper an animal is, the lower resolution you're using. So you have to decrease the frequency of your probe to obtain the depth that you need. And if you lower the frequency, you lower the resolution of the image that you're dealing with. So the detail you're getting in dogs over 25 kilos, the detail you're getting in the liver is, they sort of say do a CT instead of an ultrasound, because you're losing enough detail that you're definitely missing nodular changes and potentially mets and things like that in dogs over 25 kilos. So then if you go up to 40, you know that you're missing, and then 60, 80 sort of thing, you know that you're missing things using an ultrasound just because of the machine capability. And then the other sort of strategy that we use quite commonly to get detail is to push like closer to a structure. So if I'm looking for a 5 millimeter adrenal gland, I can't look at it from 10 centimeters away. I would need to look at it from 3 centimeters away to get enough resolution to be able to say, yeah, that's definitely it. And the way it's interacting with the vessels, it's definitely sitting there. And if there's that much fat sitting on top of the dog's abdomen, it's really hard to get close enough to actually measure things accurately and know what you're seeing. So big dogs pose a really big limitation to quality of imaging, auscultation, palpation, and being able to actually do diagnostic testing like blood draws and stuff like that. What about if you had to do an anesthetic in a 40-kilo Labrador? What reservations would you have?
A lot of the anesthetics are fat soluble.
Yeah, good.
It takes a lot more anesthetic to get them down.
Mm-hmm.
And consequently, as it leaks out again at the end, they wake up more slowly.
Absolutely. Yeah.
Well, without considering things like cardiovascular compromise.
Yeah, absolutely.
Lung function.
Lung function, yeah, for sure. Let's talk about cardiovascular compromise under GA. So if you've got the dog lying on their back, well, the cardiovascular compromise, we know that these guys have decreased cardiovascular reserve. So they're already a little bit more tachycardic than your average dog. And they've got more tissue to perfuse. But actually the heart function should be relatively normal. Let's move on to respiratory compromise under anesthetic. What are you going to see? If you did an X-ray in a dog after being in dorsal recumbency for surgery of their chest, what would you see in the lungs?
Increased atelectasis. I can't talk properly this morning. You know what I'm talking about. Increased atelectasis.
Yeah. The heavier the patient, the more squashed the lungs get over the course of an anesthetic. So then you've got decreased lung volume, and your CO2 is probably going to start heading up because of the weight of the chest wall. They just hypoventilate as well. And
then what's the Pickwinian syndrome?
Ooh, I don't know.
Yeah. The blue puffers or pink puffers.
What?
Pickwickian syndrome.
What do you mean blue puffers or pink puffers?
I've forgotten what they actually mean now. But
do you mean like the puffers, like inhalers?
I know that describing the respiration.
It's a risk of like I don't exactly know what it is. I just know it's a risk. I think it's more in feline obesity, but I know it's a respiratory complication of and I don't think it has to be under anesthetic. I think it's just a respiratory complication of obesity.
Yeah, named after Mr. Pickwick in Oliver.
Uh-huh.
Googling.
Okay.
I'm Googling. Obesity hypoventilation syndrome.
Okay, so it is a hypoventilation, like
Yeah.
you just mentioned that. Yeah.
Yeah. Triad of obesity, sleep apnea, and chronic hypercapnia during wakefulness. So are those dogs going to be pink or blue? Using Jeff's pink puffers or blue puffers.
Pink.
Hypercapnia, hypoventilation.
You would think blue, wouldn't you?
Are they? Are they? If you've got hypoventilation, what's your CO2 going to be like?
High.
High, good. And what's that going to drive respiratory rate wise?
Increase.
Increased respiratory rate. So what's your oxygen going to be doing?
Injected.
Go up.
Yeah, it usually actually stays stable or goes up because you're hyperventilating, and oxygen, the sort of restriction to the body sort of designed, if somebody designed it, I don't know, but for oxygen to be really easily what's the word when it gets in? Absorbed, yeah. It goes over the membranes really easily, so it's not hard to get oxygen in. It's much harder to get CO2 out. So every breath you take, you get a little bit of a refresher of oxygen into the bottom of the alveoli, and that will get sucked straight into circulation. But that CO2 just sits around in there and will stay high in the blood much longer than before the oxygen starts to go down. So to get hypoxemia associated with hypoventilation it's like really bad hypoventilation. There's just no movement beyond the dead space of the airways kind of thing. So they'd be pink puffers. So particularly in the situation where you've got these patients on 100% oxygen under anesthetic often, if they're hypercapnic due to hypoventilation, their oxygen is probably going to be quite good. They'll stay quite pink, but doesn't mean they're ventilating adequately. They've still got to get rid of that CO2 or they'll get acidemic and unwell.
So is that a case that every GP vet or every vet should have end-tidal CO2 in their practice, not just using SpO2?
Yes. Yep. Unless they routinely do positive pressure ventilation in their overweight patients, which would overcome that problem. So there's not going to be any hypoventilation if you do positive pressure ventilation. I mean, ideal world, Matt. We don't work there.
Yeah. No, but it's just an interesting, like if someone was like, why would I need to get ETCO2 when their dog's perfectly pink? It's like, well, we have an obese population and they could be hyperventilating.
Yeah, exactly. So you won't detect hypoventilation without an ETCO2 monitor. Okay, so just a stat that's a nice one to throw at people when you're talking about sort of increased risks of GA. Cats over 6 kilos have 3 times higher risk of death under GA than cats between 2 and 6 kilos. So it's like a curve of morbidity. So over 6 kilos, which is not that uncommon to see cats over 6 kilos. And we don't think of cats as hypoventilating that commonly because they're smaller, they're lighter, but they have much higher anesthetic complication rate than normal healthy weight cats. 3 times higher. That's very high. Okay, so let's go to really focus on that respiratory, how obesity impacts respiratory function. And we've talked about increased weight of the chest wall. And we've talked about atelectasis. What other findings might we see in the sort of awake obese patient in the respiratory system?
Oh, just physical obstruction, I think.
Yeah. Laryngeal complicate dysfunction.
Yeah, absolutely. So if we think about the sort of brachycephalic syndrome and then add obesity onto that, we're going to have increased upper respiratory obstruction, aren't we? Just narrowing of the upper airways, where it's all soft and the fat can push in on it and compress the upper airway. And then what happens in the larynx with brachycephalic syndrome or morbid obesity?
There's edema and negative pressure, and that affects the
Good.
cluster.
Yeah. So they get the saccules pop out, don't they? And obstruct the larynx a little bit. And you get laryngeal collapse. So the difference between laryngeal collapse and paralysis, does anyone know?
Well, probably
Paralysis is to do with the nerve, like the nerve doesn't, so then it doesn't adduct or abduct, one of the two.
Exactly. And it's often unilateral, like it's to do with that recurrent laryngeal nerve. Whereas collapse is pretty much just like everything gets so saggy because it's operating under so much negative pressure. And it's so edematous as well. Okay, what about the lower airways? What about just respiratory rate in a dog that comes in that's morbidly obese?
it will be increased.
Yeah.
Mm-hmm.
So the stat for today is 3 times. Just remember that for everything. Respiratory rate is increased 3-fold in obese dogs relative to normal weight dogs.
And would they be more? Is it more likely that they're like constantly panting, or that they're not panting and with a respiratory rate 3 times higher? Or is it
Probably
the
a
same
combination.
thing? Yeah.
Yeah. And I think it's tricky in a vet clinic because they're always
Excited.
yeah, exactly. Excited's a nice word
Aroused.
for it. Stressed, maybe.
Hyper aroused
Yeah.
in one way. Or
Yeah.
Adrenaline over.
So definitely increased respiratory rate. What do you think happens to tidal volume in obese dogs?
Be reduced.
Exactly. Yeah. What about total lung volume?
Probably reduced.
Reduced. Yeah, exactly. So a couple of reasons. One is fat just in the chest cavity. So we've all kind of done an X-ray in a really fat dog looking for cardiomegaly and seen that the heart's lifted right off the sternum by this huge sternal fat pad. Have you seen that? That's taking up space that the lungs would be normally, and the mediastinum's full of fat as well. So definitely decreased space in the chest for those lungs to fill, but also decreased tidal volume. With like the anatomy of dogs, so humans are upright, right? So if you get abdominal or truncal obesity in a human, you've still got gravity working in your favor to push that diaphragm back. But in dogs, they're horizontal, and you get obesity within the abdomen, and along with that, some potentially hepatomegaly, because often obesity goes with endocrinopathies, right? Pushing on that diaphragm, the work the diaphragm has to do to move the same amount as a human's diaphragm would need to do with gravity is pretty significant. So decreased tidal volume and lung volume because of that shift in the diaphragm position, and increase or decrease movement of the diaphragm with every breath in. I learned something really interesting preparing for this. Who was taught that dogs don't get bronchospasm?
yeah, I think.
Yeah. So they've demonstrated that obese dogs have increased bronchoreactivity. They actually get bronchospasm, which is interesting because we've always sort of thought cats are the better model for human bronchial reactivity. But all of a sudden with obesity, dogs start to behave a little bit more like humans and cats, and only in that situation. They haven't really demonstrated bronchospasm, to my knowledge, in any other situation. So what airway diseases do we see that might lead to where bronchospasm might be a big problem for an obese dog?
Bronchitis, canine chronic bronchitis.
Exactly. Yeah, chronic bronchitis. Another one?
Wouldn't be any like bronchopneumonia.
Oh yeah, for sure. Yeah, and in which case you've got inflammation, which might then exacerbate the bronchoreactivity. But when I think about airway disease, I think about kind of all of the different sections of airway. So I kind of worked my way down thinking of differentials. So trachea, what tracheal disease might be exacerbated by bronchospasm?
Dynamic airway disease.
Yes, I think that's the big one. Yeah. So if we've got bronchomalacia, tracheomalacia, and then we've got bronchospasm on top of that floppiness of the cartilage, it's really going to decrease tidal volume. And it is all of a sudden, because there's sort of, when I was taught and when I was kind of studying, so up until 6 or 7 years ago, there was no sort of discussion of bronchospasm. But a lot of authors still say you should be using Ventolin and an inhaled steroid in dogs because the outcomes are better. And it's very anecdotal. There's no data to actually demonstrate that, but all of a sudden that sort of makes a bit of sense. A lot of these dogs are overweight if they've got bronchospasm in addition to the collapsing.
Do they know what mechanism triggers it in obesity?
Not that I know of.
So you just have to look at like what causes the kind of atopic march to asthma in cats and humans.
Oh yes, no, yeah. So it's unlikely to be allergic. Yeah, I don't know what it is. They might, I don't know, they might know, I don't know. So in humans, and we can't compare humans to dogs very well because the bronchoreactivity is different. But in humans, obesity is associated with progression of bronchomalacia, tracheomalacia to chronic obstructive pulmonary disease. So if they're fighting for air and they've got increased resistance to either inhalation, exhalation, or both, and then you've got bronchospasm, which exacerbates that. So chronic obstructive pulmonary disease is where the resistance to expiration is so high that it actually blows out the bottom of the bronchi. So it puts so much positive pressure in the alveolus and bronchus trying to get the air out of the lungs that it actually distorts the anatomy of the bronchus. So where you've got a bronchus that should always taper as it goes to the periphery of the lungs, all of a sudden it starts to get a little balloon down the bottom of it. So we rely on that taper and we rely on the wall being healthy and not inflamed to move mucus, which like there has to be a degree of mucus produced in the bottom of the lungs to clear inhaled particles out. And what's that mechanism that moves that mucus and inhaled particles up out of the airway?
Oh,
mucociliary apparatus.
Yeah, exactly. Mucociliary escalator. So that's reliant on the escalator. So if you think of an escalator, it has to go like that, right? It can't go like this. It doesn't work. So if you've got a big balloon down the bottom of the bronchus, the hairs don't meet properly, they can't move stuff up properly, and you get decreased function of that mucociliary clearance, predisposes to pneumonia, decreased like VQ mismatch because there's just crud in the bottom of the alveolus and you don't get gas exchange. That's the word I was thinking of before, gas exchange.
Oh.
Yeah, you don't get gas exchange occurring as appropriately, in addition to with obesity, that decreased tidal volume, decreased respiratory function. So obesity is a huge thing to address in dogs with respiratory or airway disease, I would say. Particularly given it's chronic and progressive.
Annie, you mentioned before that it basically gave the impression it was easier to get oxygen across membranes than carbon dioxide.
Yeah.
My understanding was the opposite.
Ooh. But then it doesn't make sense if they're hyperventilating.
No, that's right. It doesn't.
Yeah, because that's how we diagnose hypoventilation, particularly in tick patients. If they've got chest wall paralysis and they're not moving enough air, they've still got normal oxygen mostly. It's a little bit lower, but it's the CO2 that goes up before the oxygen goes down. But should we put that on our homework list?
Yeah, on someone else's homework list, yes.
Yeah. Oh, you did such a good job on the Avabradine homework. I was thinking about that today. I put that tutorial up on YouTube like we always do. And I was actually thinking I really probably should need to do an amendment on the end of that, because we sent out an email saying that this is the mechanism of action. But yeah, I probably need to edit that and add your homework onto the tutorial for anybody that watches in hindsight.
Yeah, but the author's permission is granted with as long as there's
Thank you.
to the author's identity.
Yeah, am I allowed to quote you?
Yes.
Thank you. Cheers, Jeff. Okay, let's talk about cardiovascular disease. We sort of mentioned it a little bit with our GA. Is there a huge impact? Do we know about much of an impact of obesity on cardiovascular disease in dogs and cats?
Not that I know of.
Not really.
You can get hypertension in obese dogs, but it's like the whole like atherosclerosis and stuff that we get, they don't really get.
Yeah.
Or is hypothyroidism somehow linked? I can't remember.
Linked to atherosclerosis?
Yeah, I don't know. That just came up in my mind. So
Yeah.
Yeah, I similar to Anna's point around the bronchioreactivity, I have a feeling atherosclerosis has started to be mentioned in the canine, but I think obviously as a carnivore, like it just doesn't seem to like happen to date. But I think it's kind of emerging. But I could have made that up.
Yeah.
It is. There's like genetic kind of reports of atherosclerosis. So golden retrievers are overrepresented with atherosclerosis, but golden retrievers are also overrepresented with hypothyroidism. So what is the mechanism of atherosclerosis?
Isn't it endothelial damage, vascular damage, and then the plaques, like the LPLs and other mediators come and like plug the micro damage to the vessels and then form a plaque.
What's LPL?
Like LDL, low density lipoprotein.
Yes, good. Okay, so what are the plaques made of? If they put their cholesterol, good, exactly. So one of the reasons in humans that cholesterol is so closely associated with the incidence of heart disease is because the more cholesterol you have in your system, the more capacity there is for cholesterol to be deposited in the walls of damaged blood vessels. And those walls that accommodate the highest shear stress are the arteries close to the heart, right? They're the ones that are carrying the most blood under the most pressure.
And does calcium play a role in those plaques as well? Because I think there's a lot. Yeah.
I think inflammation causes calcification. But the cholesterol, like your endogenous calcium level, if you're hypercalcemic, you're not more likely to develop atherosclerosis. Whereas if you're hypercholesterolemic, you are more likely to, if that makes sense.
I think a lot of talk about using vitamin K2 to pull calcium out of your blood vessels to reduce, like reverse, go part of the way to reverse your atherosclerosis progression.
So
and they're using like a scanning technique, like an X-ray calcium. I don't know the exact details, but they measure calcium in vessels as a way to like determine heart rate.
Yeah.
Dietary magnesium can also eventually replace the calcium and reduce the plaque.
Yeah.
Oh,
Magnesium orotate.
Only orotate.
Oh, that's the one that they're using in humans.
Yeah, right. Magnesium, I think, is just the wonder electrolyte. Don't you reckon? Fixes everything, impacts everything, fixes everything. So atherosclerosis. So Matt mentioned the LDLs, which are low density lipoproteins. Does everybody know what they are? Sort of. This is foggy to me. Like the way that I was taught this, I didn't get it at the time, and I spent a lot of time trying to get it and then promptly forgot it again. So essentially I think of the LDLs, HDLs, you know how when they do human blood tests, they talk about good cholesterol, bad cholesterol? They're shuttles that carry cholesterol around the body, those lipoproteins. So they're just like little UFOs in the bloodstream with cholesterol attached to them. Let's think of them like that. And they carry ingested cholesterol. LDLs carry ingested cholesterol to the periphery and facilitate deposition of the cholesterol in peripheral tissues via an enzyme called, I'm going to cheat, sorry.
Yeah, it's mentioned in Ettinger and I can't remember it.
Yeah. Did I write it down? No.
Is it a kinase?
Cholesterol ester transfer protein. That makes sense. It's not an enzyme at all. It's a transfer protein. So LDL carries the cholesterol to peripheral tissues. This cholesterol ester transfer protein facilitates deposition in those peripheral tissues. So firstly, dogs and cats have very low levels of LDLs just innately. So there's very little movement of cholesterol to peripheral tissues. They've got a much higher percentage of HDLs than LDLs. So if you've got less carriage to the periphery, that's a positive, and you're going to get less atherosclerosis. But they also don't actually have that cholesterol ester transfer protein. I'm going to say it so many times so I can remember it. So they don't have that protein where humans do. So the cholesterol can't actually get off what little LDL it has and jump onto peripheral tissue. So where they say there's some genetic sort of ability to develop atherosclerosis, those are the dogs that have got that protein. Shouldn't speculate, but I'm assuming that's the genetic difference between those families of dogs that have atherosclerosis. So then if LDLs take cholesterol to the periphery and facilitate deposition, what do you think the good cholesterol does?
Brings it back.
Yeah, but the good HDL does, yeah. So HDL brings cholesterol from the periphery and takes it back to the liver for processing. So dogs have a much higher percentage of a good carrier, the HDL. And so most of the cholesterol is moving from the periphery, if it's there in the first place, and moving back to the liver. So we just don't get the problems with high cholesterol that humans do in terms of cardiovascular impact. Having said that, there is a level of hypercholesterolemia that there is no amount of HDL that can carry it around. So particularly the dogs with really profound familial hypercholesterolemia or like hypothyroidism that's really poorly controlled, hyperadrenocorticism really poorly controlled. If the cholesterol is really extremely high, we could potentially get deposition. So the dogs that had the atherosclerosis were hypothyroid or hyperadrenocorticism.
That's due to like a pan hypercholesterolemia.
Yes, yeah.
And that's because, did you say that's because it's like there's not enough carriers to even mop it? Like there's not enough HDL to bring it back to the liver for processing.
Even though they've got
like overwhelmed.
The capacity, yeah. So what in humans, what does atherosclerosis lead to? Why do we worry about plaques in blood vessels?
Thrombus?
Thrombus, yeah, exactly, which results in what tissue damage?
Of hypoxia.
Yeah.
Ischemic.
Yeah, ischemic tissue damage. What organ is the most commonly reported to cause a very dramatic
Myocardium.
Myocardium, exactly. So we don't really see ischemic heart disease in dogs and cats, which is the most common cause of heart disease in humans, because we don't get the atherosclerosis. We do get, so I want to go back to hypertension that Josh mentioned. Is that significant? It does happen. Like the obese dogs will have blood pressure 10 to 15 to 20 millimeters mercury higher than normal weight dogs. But it's still usually within that regulatable range where it's not going to cause intracranial hypertension. It's not going to cause glomerular hypertension on its own. So it's probably not significant. And the consensus statement says that obesity has minimal impact on pathogenesis of canine and feline hypertension. So we can sort of say,
it's like a relative hypertension.
yeah, the blood's got to go further.
So the like the metabolic syndrome X, it doesn't then really look the same if it does in dogs as humans.
Can you tell me what metabolic syndrome X is?
Metabolic syndrome is like obesity, hypertension, and other cardiovascular disease, and I think maybe non-alcoholic fatty liver disease as a cluster in humans.
Yeah, right. So our metabolic is different. Yeah.
Yeah.
Because that would then, I have heard of that metabolic syndrome where you have hyperinsulinemia.
Insulin, yeah. So it's insulin. It's
and
insulin, obesity, and blood pressure.
Yeah.
So it includes high blood pressure, high blood sugar, excess body weight, abnormal cholesterol levels. The person's increased risk of heart attack and stroke.
Yeah.
So it's not the liver.
Ours is different. We do get some heart changes. So if you've got if you've got slightly increased hypertension and that heart's just got to work a little bit harder to push blood to increase tissue that it wasn't really designed for, what will happen to the left ventricular wall?
Hypertrophy.
Did you say that too, Josh? I think you're muted.
Yes, become thickened.
Yes, exactly. So if you measure, obese dogs have increased wall thickness relative to normal weight dogs, but most of the time it's subtle and it's certainly not clinically significant. What about the dogs that have degenerative mitral valve disease and go into failure? Has anybody heard of I've forgotten the name of it, that overweight dogs actually have longer survival times than healthy weight dogs?
Mentioned in Ettinger, I think.
Yeah, so there's like a paradoxic surprise kind of increase in survival duration in dogs that are just marginally above the normal weight range, because they've got longer before cachexia results in quality of life issues. However, if they're morbidly obese, the survival drops down again. So survival, when you look at it, so if you've got like body mass index down the bottom, or body condition score down the bottom, and this is 1 and this is 9, and we're looking at survival time, it's going to be a U-shaped curve. So very lean dogs have low survival, morbidly obese dogs have low survival, but the dogs in between, they're kind of the center is over 6 rather than 4 or 5 of the U. Longer survival in slightly overweight dogs. So I don't do calorie restriction in my heart failure dogs, but unless they're morbidly obese. What else?
The same is true for exceptional determinant. Like there's a study on exceptional determinants of longevity, and they find that because they're using DEXA composition scans for dogs, like actually predict how long a dog's going to live when they get to like kind of 11, 12. Like if a dog's starting to get fat at like 14, then they're going to live a really long life. So that it gets to a spot where you actually want because I think it's associated with frailty as well, like obviously muscle loss, but also if you start to actually put on fat during like a time point, 2 time points, then it actually is a strong predictor of like lifespan.
Oh, interesting. I'm going to start feeding my dogs up when they get to 12. I run them pretty lean at the moment. Okay. I want to move on to urinary disease and skip musculoskeletal disease because it's boring. Does anyone want to talk about osteoarthritis and cruciate ligament disease?
But I can gather it's the one thing that's most affected in obese cats.
Oh, wait, osteoarthritis for sure. Yeah. 5 times more likely to present for lameness. So that's, sorry, I've broken my 3 times rule. Not my stats.
On cruciate, that I would want to mention about cruciate is whether the hormonal cascade differences from obesity contribute more than the kind of load, because like spayed female dogs are something like 6 times higher to do a cruciate than other categories. And is that because estrogen plays they think like I've sort of interpreted that estrogen plays a role in ligament health. So does obesity, is it not just mechanical shear loading issues associated with obesity, or is it more the pro-inflammatory cascade or the hormonal changes associated with obesity that rupture the ligament?
Yeah. I don't know whether it would be possible to do a study to tease out what influence what has, but certainly obesity is associated with hypermobility of joints, which is not what you'd expect. Like if they're carrying around a higher load, they're probably actually quite strong, and they should, in theory, have quite stable stifles if the quads and glutes have been carrying quite a high load. But often we see these obese dogs with very lean little stick legs, don't we? You can picture it. So they actually have increased joint mobility. And I'm not sure whether that's the association with endocrine disease, because we know that dogs with Cushing's are more likely to rupture cruciates. Is that atrophy? Is that truncal obesity? Is that hypermobility of the joints? Don't know. And is it the obesity associated with that causes that, or is it the endocrinopathy that causes that? I don't think you could run a study that excluded, like you can't really exclude Cushing's, early Cushing's and stuff like that. It's hard.
Yeah, maybe the diet that got them fat in the first place being deficient in protein, so having less muscle, being sarcopenic as well.
Yeah, certainly poor quality diets. Yes.
Mentioning the nutritional as a
Well, it is for sure, but I think there's so many factors that would play into the increased incidence in obesity. Disc disease, obviously fat dachshunds, you look at the load on their back and go, oh no.
Yeah, that's increased as well, that risk.
Yeah.
Apparently joint health depends a lot on the pumping action of weight bearing on the joints.
Less
loading and unloading to express the like the cartilage pads, as it were, they're in and out. And I would think obese animals and people would exercise less because of cardiovascular.
That's a good point.
Cardiorespiratory problems, and therefore the joint problems would follow.
Yeah, that's a big point.
My theory, anyway, but
I like it. All right. Let's talk about urinary disease, because we've actually managed to drag this out right through the hour. I was like, there's so little in this topic. Hopefully we haven't been prattling on too much. Okay, how would obesity impact the urinary tract?
Incomplete emptying.
Good. Yeah, which it predisposes to
UTI.
Yeah, good.
And probably
the kidneys enlarge, apparently, the glomeruli enlarge, and consequently, what happens there? It draws the cells apart, and they. Now I've forgotten. I only read it last night.
I'm really impressed that you got that far. So I found this really interesting. So obesity is associated with renomegaly. The kidneys enlarge with obesity. And the glomerular, if you kind of look at renal size and glomerular size, the glomerulus itself increases in size relative to the renal size increase. So when you've got a glomerulus, which is like a filtration membrane, like if you've got like a colander, if you're thinking of like straining your pasta and you stretch your colander, the holes get bigger, right?
Yeah.
So if you've got the podocytes, which are normally sitting right next door to each other, being stretched apart, you get increased gaps, that those filtration slits get bigger. And then we get what happens when you've got damage to that filtration barrier. Proteinuria, exactly, which will progress to
renal damage.
Renal damage, exactly. So you get tubular damage and damage to the ultimately chronic kidney disease. So if we've got proteinuria, we call that, even normal creatinine, we call that stage 1, IRIS stage 1 kidney disease. So proteinuria associated with obesity is not definitively reported in our patients, but it's probably there. The studies that have looked at it are inadequate numbers and design. So it's definitely something that if you've got existing renal disease, I'd be concerned about watching for proteinuria in these patients. What about obesity's impact on RAS?
Oh, yeah, it does.
Time out. Somebody.
It does
Screen
affect.
freeze. Did the Zoom freeze?
Is it freeze? Sorry. Sorry, Jeff, I missed that. What did you say?
I only read it last night, and I just can't remember. It does increase it, but I don't remember the details.
Exactly. So if we've got upregulation of renin, angiotensin, aldosterone system, what's the impact on our blood pressure?
Goes up.
Goes up. What's the impact on our glomerular pressure?
Goes up.
Goes up. Exactly. So we've got increased pressure on the glomerulus already, with potentially some stress on the podocytes and the glomerular filtration membrane. Tell me about the association between idiopathic cystitis in cats and obesity. Does obesity cause it?
This is more a correlation.
Yeah.
It probably is inactivity associated with obesity.
Good. Yeah. So we always think of obesity as one of the things that to address in our cats with idiopathic cystitis, but we don't actually have the data to say that when they lose weight, their symptoms will reduce. It's whether the lifestyle changes we make to help with the weight, with the obesity, are benefiting the idiopathic cystitis. So it's typically indoor cats, obese cats fed on like a grazing system, so allowed to just eat however much dry food they want, are the kind of classic cats to be affected by idiopathic cystitis. But they're lifestyle things, aren't they? And all of those things are going to contribute to obesity as well as cystitis. So if you then...
Has the grazing been the grazing been a factor that's been
No.
directly?
I shouldn't say that. I should have said dry food. Maybe it has, though.
Oh no, because I mean, grazing is normally dry food because people don't leave out
Wet
wet
food,
food.
yeah.
But has dry food been direct definitive? I mean,
I said that really confidently, but I don't know what the reference was.
Lloyd Jones had a paper way back decades ago and identified indoor cats as a risk factor, wet weather as a risk factor.
Oh, interesting.
And what else? Yeah, I can't remember the rest.
Yes, I don't know, Matt. It'd be interesting. Put it on the home.
Because I mean, our observations in clinic where we have like 0 cats eating carb diets, we never get cats that block or get lower urinary tract disease, like ever in 20 years.
And what about
it just doesn't happen
on those diets?
The what? Sorry,
incidence of obesity on those diets?
They don't get obese on those diets.
Yeah,
doesn't happen.
Yeah. And then what about stones?
Increased
stones is... Oh, sorry, you go.
Well, that's all I was going to say. Increased calcium stone risk.
Yeah.
In humans and in cat. I'm not sure now. Cats or dogs?
I think cats. Yeah. Oh, I think dogs as well, actually. But I don't know what the mechanism of that is, and it didn't mention it in Edinger what the mechanism is. So I presume that when this edition was written, they didn't know. But hopefully, next time we get to this chapter, we'll have an answer in 3 years.
Is it?
We've been running these tutorials for 3 years, and we've just gotten to the end.
is it about I think there could be something about so calcium oxalate, remind me, I've been on leave for for most of the year. Calcium, you're talking about calcium oxalate
Mhm.
risk.
Yeah.
And so is oxalate the one that you get from bacterial infection in the alkaline environment, or the other way around?
True, but is that one?
True, right. Okay. So yeah, okay. So there's possibly a dysbiosis associated with Oxalobacter bacteria that promotes calcium oxalate that could be involved from a microbiome perspective for calcium deposition. That could be the same dysbiosis associated with obesity.
Is that humans or dogs? Do we know?
Dogs.
Dogs. It would be so interesting to look at the breeds predisposed to calcium oxalate and see if they genetically have higher representation of that bacteria. Anyway,
That study has.
No. Can you do it?
Maybe.
I better wrap up. Actually, I'm impressed that we managed to get through a full hour of obesity, but that was a good discussion. Thank you, everybody, for joining in.
Thank you.
And as I said, in one fortnight, we're going to be doing concurrent infection and immune suppression. Let's try and make it as case-based as possible and talk about, and as I said, I'll just do a review of the immunosuppressant medications, their mechanisms of action, and how we're going to decide what to use with minimal impact and balancing those two conditions. Cool.
Thanks, everyone.
Thank you.
Thank you. See ya.
What's the diet that the cats don't get fat on?